And welcome to today's session, Leading with Outcomes. Going ahead, this is our disclaimer, just a reminder, next slide, that we are funded by the Substance Abuse and Mental Health Services Administration. The content of this session may not necessarily reflect the views of SAMHSA, the Department of Health and Human Services, or the agency I work with, Center for Applied Research Solutions. So for those of you who are not familiar with the Pacific Southwest MHTTC, we are part of a national network of technology transfer centers and serve SAMHSA's Region 9, which includes the US Pacific Islands, Hawaii, Arizona, Nevada, and California. And with a map here, you'll see each region has 3 different colored boxes. The blue boxes represent the addiction TTCs, the green boxes are the prevention TTCs, and the orange boxes, which include our center, are the mental health TTCs. Many of you are joining from all over these areas and beyond, which is wonderful. And if you're not from Region 9 and haven't yet connected with your specific region's TTC and you'd like to, please do reach out to us, as we'd love to help link you up to any center you're seeking. I need to go ahead to the next slide. So our role here at the Pacific Southwest MHTTC, we provide training, technical assistance, and resources to support the mental health and school mental health workforce in our region to adopt and implement evidence-based practices across the mental health continuum of care. Next slide. Shows the services that we have available. We offer no-cost support to the mental health and school mental health field through webinars like the one that we're on today, as well as through coaching, consultation, resources, and tools. We also have a great newsletter that goes out on a quarterly basis, and someday soon we can continue our in-person trainings and events. Moving on to the next slide. This graphic here shows our technical assistance tiered process. I'll just go ahead and move on to the next slide. Just to show that our MHTTC language, we use affirming, respectful, and recovery-oriented language in all activities, as you can see here. We are oriented to person first, non-judgmental communication. We strive to be inclusive, strengths-based, and clear. We invite you all to join us in these values. Okay, moving on to the next slide. I'm so honored to have Third Sector and their co-presenters and collaborators join us for today's session, and I'm going to hand it off to them. Thank you so much.
Great. Thank you, Ingrid, and thanks so much, everyone. It's really a pleasure to be here with you all today. My name is Aurel Amram. I'm with Third Sector. I'm a director based out of our San Francisco office, and we've got a wonderful team here with us today who will introduce themselves throughout the presentation. So really excited to hear from our colleagues and partners in Los Angeles County's Department of Mental Health, San Bernardino's Department of Mental Health in California, and the Mental Health Oversight and Accountability Commission out of California as well. I'll spend the first few minutes giving an introduction to a little bit more about who Third Sector is, and then you'll get to hear from all of our wonderful partners directly. We're going to have plenty of time for Q&A at the end of the presentation, so we'll make sure to answer those questions at the end, but we won't be answering them during the main body of the presentation. That said, if things come to your mind, a burning question on your mind, please feel free to drop it in using the Q&A function at the bottom of your Zoom box. There'll be an option there. So we'll be monitoring that throughout so that we can make sure we answer your questions with the time that we have held at the end. Really looking forward to the collaborative discussion today, and we'll also have some interactive portions as well. So keep an eye out for those throughout. Nicole, if you don't mind flipping to the next slide. Our agenda for today, as I mentioned, I'll start by providing an overview of some of the foundations and principles of an outcomes-focused mental health approach and a little bit of background and history on California's journey to improve services and outcomes in our state. We'll then hear from our partners at Los Angeles County's Department of Mental Health and some lessons learned from their 3-year journey to transform their outpatient mental health contracts and services. And then we'll move to hearing from San Bernardino County and our partners at the State Mental Health Oversight and Accountability Commission in California. And at 3 o'clock, we'll transition to question and answer portion until 3:30, and that's Pacific time. So if you're in another time zone, might have to adjust those numbers. Next slide, please. As Ingrid mentioned, we also really take a person-first approach to our work. And we wanted to start by sharing an example of the way that mental health systems can impact individuals on the ground and the types of changes that we seek to make in people's lives on the ground through our systems change work. So wanted to highlight the story of Jay. Jay is a 34-year-old man living in Los Angeles County, for example, who has serious mental illness. He has struggled with cultural stigma and a transient lifestyle that's made him, difficult for him to access treatment and maintain housing. He is a frequent utilizer of emergency services for psychiatric and physical health reasons, but he hopes to eventually find a job and get back on his feet. Last week, for example, Jay might have been approached by a street outreach team about the opportunity for assertive community treatment-based mental health services. Just as an example of the type of systems change that we work to create with our partners using an outcomes-focused approach and the principles of an outcomes focus that we'll talk through in a few minutes. Before the transformation, Jay might have been referred to a specialty provider to meet his needs, but they might have had limited capacity. We know that our mental health systems across the country are struggling with urgent need coming out of the COVID-19 crisis and so many other crises happening simultaneously. Another instance is that Jay's provider might not have had a nurse on staff nor an occupational therapist really to assist with his multidisciplinary needs. And then he might not have been able to quickly access housing resources because that provider might not have been sure which services are most helpful to people like him. What we've worked with LA County and so many other partners to implement is an outcomes-first approach that also has human impacts for folks on the ground like Jay, in addition to systems level impacts. So after an outcomes focused transformation, Jay might be able to be connected to services in one day, and his provider would be properly compensated for working with individuals like him through something like bonus payments or other funding structures that understand the complexity of his needs. That would also be met through staffing changes. His physical health and employment goals could be met due to the new multidisciplinary team available to support him. And his provider would participate in a learning community where they could learn about best practices for helping people like Jay, learn from other providers, and ultimately help Jay find and maintain housing. So just a case study, an example of the type of change we seek to create through an outcomes-focused approach. Next slide, please. We wanted to hear how much this story resonates with you. So as our first interactive portion of this webinar, and we'll be doing this a few times throughout, so this is a great practice. If you can open up your phone or computer, whatever device you have handy, and navigate to slido.com, and then type in the code MHTTC. We're curious to hear from you all today how much the story of Jay resonates with you and the individuals in your community. So let us know. Hopefully you can vote 1 through 5, whether Jay's story resonates. We'd love to hear, just to start, where everyone is at. And hopefully that technology was straightforward. You can also scan the QR code using your phone if you've gotten used to that technology during COVID. I see some responses coming in. That's great. I'll give it a few more moments to populate. Looks like it's really highly resonating with everyone, seeing a lot of 4s and 5s, no 1, 2, or 3, and that's great. glad to see that the content and issues we'll be talking about today are relevant for everyone. There's so many crises happening simultaneously, crisis of systemic racism, of mental health needs, pandemic is still ongoing, housing crises, substance abuse prevalent across the country. And there's so many simultaneous challenges for us all to work through. We're hoping that some of the tools and principles for systems change that we discussed today will be relevant in your community. I'm enjoying watching this tie between 4 and 5, really back and forth across the 50% mark. Great. Well, in the interest of time, let's keep moving with an average of 4.5%. Love that. So just a little bit more about who Third Sector is and the types of work we do and some of the principles that we think can be really useful in outcomes-focused transformations and broader systems change in the mental health world. So as I mentioned, Third Sector is a 501c3 nonprofit organization, and our mission is to advance improved and equitable outcomes and help government leverage data and lived experience to improve outcomes for people like Jay to solve the stories that we just talked through. We take what we call an outcomes-focused approach, and that's a lot of what we hope to share with you about today. Some of the basic foundational principles of what an outcomes-focused approach means and how that looks on the ground with some of our partners implementing that today. Our approach puts outcomes, and especially equitable outcomes, so reducing disparities, at the center, and then orients everything else around those outcomes. So thinking about how we can align funding with flexible money to fund coordination, innovation, and continuous improvement, breaking down silos, how we can share data across service providers and government rather than a one-way flow of information to better understand which services are working and not working and how our approach might be adapted. Using that data to make data-informed decisions about policy and programmatic changes, and ultimately ensuring that policy ties dollars to outcomes, knowing that we're getting the results that we hope to see. These types of system changes that put outcomes and equitable outcomes at the center also sometimes require changes in internal culture and external relationships. So building more collaborative relationships across service providers and government, and more trusting contracting and service relationships. Next slide, please. The foundation of an outcomes-focused journey is working through an 8-step sequential process that helps government and communities accomplish that vision that I just walked through on the previous slide. So we start by setting goals and building consensus on what the most important outcomes from a program are. Then we use data to analyze and understand what the current performance is. We build partnerships to cut through silos and foster multi-stakeholder collaboration. We think about what incentives might be important, whether financial or non-financial. Sometimes sharing data and just offering more resources can help get folks to the table. We implement a new approach, and then we evaluate to understand what worked and didn't work, and ultimately continuously improve and scale across the system, repeating this cycle. Next slide, please. We've brought this outcomes-focused approach and some of these principles of an outcomes focus to California's full-service partnership program. I know today we're joined by individuals from across the country, which is really wonderful. So for those of you who aren't based in California, we did want to provide an overview of the program that we're going to be thinking about and talking about today, really just as a case study, although we believe this outcomes-focused approach can be applied to any mental health service and really any social service, whether it's in the realm of behavioral health or otherwise. And we partnered with other jurisdictions across the country to do so. But just a little bit of grounding and background on the importance of full service partnership to California. It's meant to deliver a whatever it takes approach to comprehensive community-based mental health services. It's a very important investment of taxpayer dollars in California, serving over 60,000 individuals and families experiencing severe emotional disturbance or serious mental illness. Providers deliver a diverse range of evidence-based services across the gamut of therapy, psychiatric services, peer services, housing, case management, and so on. And FSPs provide really consumer-centered services to achieve goals. Counties are provided substantial flexibility, but that has sometimes made it challenging to really understand the statewide impact. And that's a lot of the questions that we've been working through with our partners on the webinar here today to figure out how to continuously improve. Next slide. And so, as I mentioned, we've had some really wonderful collaborative state partners who have been leaders in innovating and bringing this outcome-centered approach to full-service partnerships across the state. That journey began with LA County Department of Mental Health, trailblazing starting almost 4 years ago to transition their $300 million in services and spending every year of FSP services to focus on outcomes. And that new approach, after a lot of hard work and effort, launched on July 1st, just a few weeks ago. And that inspired 6 other counties, now 8 counties, we've got 2 more joining, to collaborate with the Mental Health Services Oversight and Accountability Commission, as well as other partners in the state, to think about how to build on LA's outcomes-focused transition for mental health services and really build statewide momentum, again, following that journey of scaling and continuously improving the approach to help keep it focused, centered on outcomes for those individuals on the ground. So that's just a little bit of background about third sector, the foundations of an outcomes-focused approach, and what some of our partners have been working on. But we want to turn it over to them so that you can hear directly. So I'll transition it over, if you don't mind going to the next slide, to our partners at Los Angeles County's Department of Mental Health to share a little bit about their work for the next few minutes.
We really have been thrilled to work with third sector as our partners in taking a look at, what we're doing with FSP. It has been a tremendous undertaking. There have, been a lot of gains, but also a lot of challenges. We were very happy that as of July 1st, we were actually able to implement. And FSP is LA County's most intensive outpatient program. We provide crucial community-based services and supports for our most vulnerable and high acuity individual. And as Aurel mentioned, it really has been a whatever it takes approach to client recovery and well-being. So we have a pretty large FSP system of care in place in LA County. It spans about 196 providers, around 2/3 are contracted, about 1/3 are directly operated. We see over 15,000 clients each year spanning all ages, and we have over $300 million in contracts and services. And we've been doing FSP under our Mental Health Services Act for well over a decade now. And so we figured with, this experience under our belt, it was really time to take a look at what it would take to take LA County to the next level. We've had a tremendous number of successes, where we've intervened in people's lives and really made that difference. Because one of our goals, besides taking care of our highest acuity, most vulnerable population, has been to be able to keep people in community. I think that has been such a priority for the department. And a lot of times FSP is kind of the last stop before people enter into other systems, such as the justice system or homelessness or longer term institutionalization. So, we have really stressed the importance of not just doing well and making a difference in people's lives, but taking the resources that we have and leveraging them to do even more with what we have, to take the experiences to build on and try a new approach. And I think, having this outcomes focus versus like a utilization focus, for instance, has really been a way for us to take a fresh look at what we're doing and what we can put in place to support and incentivize all of our providers across the system, and hopefully build a stronger, more resilient, more responsive FSP system for our clients. So I think we're ready for the next Slido.
Great. So yeah, LA County worked so hard to build buy-in for this FSP transformation, and we're going to get into the details of how that happened. But we'd love to hear from you all first. What is the most challenging part of building buy-in for a large initiative in your community? And we have some suggestions of what we think it might be just based on our experience. Great. looks like a lot of the items that we're going to talk about and a lot of the factors that LA County had to work through, including building capacity for providers, maintaining focus with competing priorities, ensuring there's a positive impact for folks on the ground, and the local politics are all high priority challenges and systems change efforts. So hopefully a lot of the journey of LA County will resonate with folks.
And I think these poll results, Earl, are very telling because as you watch it come in, it's like constantly shifting and it's almost a four-way tie at many points. And I think navigating that for us felt like this, that on any given day, it could be sort of a different kind of challenge. But Silva, Dr. Alex Silva is going to talk to us a little bit more.
Good afternoon. Buenas tardes todos. Good afternoon. Hopefully you guys are doing well. My name is Alex Silva. I am the program manager over a countywide FSP administration. Yeah, it is very telling, Lisa. Absolutely, 100%. It's interesting because I'm sort of focusing on what the challenges are. I'm always focused on how to build. You know, how do we build that link? How do we create? And I think for me is create that communication and dialogue with stakeholders and being able to have that. And my preamble to this screen or this slide here is really that a key to being able to establish a higher degree of buy-in is in establishing the link really between the project and the stakeholders' values and motivations. That cannot be done without direct dialogue. Cannot be done without direct dialogue. So you have to be open. You have to listen. Be open to change. You have to be able to look at, understand what's worked, what hasn't worked, and collectively problem solve to really look and improve the actual program and the system as a whole. And that's exactly what this slide is showing. Since 2018 till now, and for the next 3 years, if not more, it's an ongoing, for me, a PDSA. Plan, do, study, act cycle. It really is. So we, as you can see in 2018, where we started was really listening, listening and learning, being able to communicate, have that direct dialogue with clients, providers, DMH staff, and our counterparts, as well as county stakeholders. God, these numbers seem so low. I see the plus, but with clients, I think it was well over 40 clients were engaged in feedback and surveys. Over 20 staff engaged in 6 work groups. We had providers ongoing with various provider focus groups, a lot of surveys. We had well over 60 respondents on those surveys, getting more feedback. Again, we had county stakeholders, at least 9 other divisions and agencies shared feedback. And we'll get to that. So as you can see in 2019 and 2020, that's where the collaborative implementation. Again, all those focus groups continued. We never stopped communicating. That was essential. Working with the various work groups to establish the new eligibility criteria for FSP program, service guidelines, referral pathways, data systems, outcomes, funding and incentives. Again, we're looking at having smaller groups, larger forums where we discussed all this. Nothing was hidden at any point. It was open to the public. This is what we're doing. Tell us what you think. Give us your input. We'll revise, we'll update. And that's what we did. Challenging due to the size of LA County, to say the least, but we were able to do that. We had at least 4 all provider updates and QA sessions on top of our separate FSP provider meetings with providers and those individuals in the trenches. Of course, county stakeholders such as our Board of Supervisors, CEOs, the Office of Diversion and Reentry, Probation, Department of Health Services. We continued that ongoing communication. And last but not least, coming to 2021, as everybody says, July 1st, we implemented, we rolled out. There's no such thing as a perfect system, right? We all agree to that. There's no such thing. And I think we always have to look at it. There is challenges. But from here on out, the next 3 years, as Lisa's mentioned, we're looking to kind of look at this as a pilot project and being able to move and change and be flexible, be fluid, because that's the only way we're going to be successful. So on top of the pilot, we did, shape the same providers. We wanted to make sure that this was as seamless as possible with the various programs and the various changes. And again, we continue to plan and learn from this pilot and from here, from the next couple of years. Next slide, please. And again, I know Aurel's on here. I know she didn't check out or didn't take a break. So I'm going to ask Aurel too to jump in here, interject whenever you need to. I like to do a little shout out with Third Sector. Third Sector has been, to me, amazing. What a collaborative. I mean, they were hands down. I was so impressed working with Third Sector. The team, Aurel and her team, were amazing. To be able to conceptually come up with what we have and push us as a department with all the red tape and all the politics, move things forward to the point that we're here today. And I think one of what we're looking at is really looking at outcome-focused performance outcomes and looking at who do we want to treat. We revise our eligibility criteria to really hone in on those individuals that are really most in need of these services, not those that are potentially will probably benefit in a couple of years if they don't continue, that they don't improve. We want to make sure we're addressing and ensuring that these services are being delivered to those vulnerable populations. And God knows there's a lot of, they're all priority populations. So we're looking at these high acuity, those that are chronically street homeless, those that are justice involved, those that are high utilizers of emergency and inpatient services. And obviously the priority outcomes with these particular populations is one, we want to make sure that there's housing stability, right? Those that are on the street, we don't want them on the street. We want them to find a safe place, a safe haven for them to really participate in the treatment. Again, reducing justice involvement and also reducing the ED utilization, ED visits, psychiatric hospitalizations, and so forth. With all this said, without the supportive infrastructure in place, we would be lost, right? Part of that would be the evidence-based services guidelines, leveraging the ACT model, the team-based approach, making sure that we're clear on what the eligibility criteria and the referral process is. Again, capacity building, clinical technical assistance. We've also have another phenomenal partner with UCLA, Public Mental Health Partnership. They've been phenomenal in providing technical assistance, the training that you need in order to move forward and deliver these services successfully. Learning metrics to understand drivers of improved outcomes and actionable data reports and continuous improvement process. So what that means is that we're also working with our outcomes division and formulating, developing reports, data to inform our decisions moving forward, to ensure that these bonuses that we're looking at providing our legal entities are meeting the metrics and getting to the point that where we want them to get to. Well, with that said, I think I'm out of time by 1 minute, but we'll be here for questions. Thank you.
Great. Thanks so much, team. I think you covered everything. I have nothing to add, Alex or Lisa. Very appreciative of you all as partners. And now we're going to hear from San Bernardino County. We've got Michelle Dusic, and the California Mental Health Oversight and Accountability Commission. We've got Brian Sala. So I'll turn it over to them.
All right. Well, good afternoon. Thank you, everyone, for joining us. My name is Michelle Dusic, and I am the Mental Health Services Act Administrative Manager here in San Bernardino County for the Department of Behavioral Health. And we entered into this journey sort of after the fact. We were riding on the coattails a little bit of Los Angeles County. So MHSA represents about half of the funding for the public mental health system in the state of California. And so we have a lot of support from each other in terms of MHSA coordination across the state. And so LA County and some representatives from Third Sector actually came to one of our meetings and presented what they were doing and this great work. And several of us were incredibly interested in doing this. We're like, we're struggling kind of in these same areas with our FSP services and our implementation of our wraparound model. So there were really 6 of us counties that got together and said, how can we do this? We approached the Mental Health Services Oversight and Accountability Commission for their thoughts in being able to support us. And so really the things that we were looking across statewide, we often joke, we call Los Angeles the state of Los Angeles, right? And the rest of us are just kind of like trying to like catch up to them in the background. But we really wanted to do the same things. We wanted to be able to increase clarity and consistency for across counties, creating like a more consistent interpretation of the FSP core components across each county, have a similar framework. We wanted to be able to increase how counties define, track, and apply priority outcomes across FSP programs, being able to develop clear strategies and performance measures through various state level and county specific reporting tools, and then to be able to develop and strengthen existing processes for continuous improvement that leverage data to foster learning, accountability, and then meaningful performance feedback. So next slide, please. So to give you a little bit perspective about California and how different things could be, we kind of have this slide. So this is just an example of San Bernardino County, where I work and live. And we've got about 2 million people that live in an area that is incredibly large. So our county is the same size as about 3 eastern seaboard states put together. So we've got a combination of urban, rural, suburban, and frontier land in our county. And I know that sounds just, like frontier land in a huge, 2 million people county. But in contrast, like we've got Siskiyou, which is, again, frontier land, right? Frontier is often defined as counties having a population density of 6 or fewer people per square mile. And then there's like also other factors that play into it. But, Siskiyou is kind of all frontier. And then we've got this different, depending where you live in our geography in the county. And so we were really perplexed in terms of how do we make this kind of work across the state with so much diversity, just even in terms of geography. And then we look at other factors that play into diversity. And so we've got, a high population of Latino folks that live in our county. We also have, in terms of state averages, we have probably more African Americans, larger. I don't know that if it's listed on the slide, but we also have several indigenous populations that reside in our county. So we've got lots of Native American folks, Asian Pacific Islander. So we have a lot of diversity. And then of course there's, subgroups that all apply in that comparison to Siskiyou, which primarily is made up of Caucasian with some Latino and some Native American folks as well. So really kind of looking at the diversity and making sure that we move forward in creating a consistent framework was really one of the challenges that we were looking at. So what could work for everybody across the state? So next slide, please. So we really, as a cohort, and when I say a cohort, I mean the 6 counties that we're working collectively, and now we're adding 2 more, as Arel mentioned. We really took the time to define what priorities we thought we should focus on when developing that consistent framework for full service partnerships. And so really resulting in identifying some consistent outcome measures and those associated process measures, which seems like it would be easy, but really when you're looking at like what is going to work across all of the counties and potentially be used as a framework for the state, not an easy process. But really looking at what could be consistent across the state. Currently, like our regulations give us some very broad goals that we should be working on, reducing homelessness, removal of children from homes, reducing suicide, unnecessary psychiatric hospitalizations, school failure, justice involvement, and all of these as related to untreated or inappropriately treated mental illness. That's kind of what our statute says. So really kind of keeping that in mind and being able to hopefully move forward and developing a structure like that. And then we also wanted to be able to operate from consistent population definitions, right? So we have, again, in statute, some directives of things of who we should be focusing our services on. And so, but things like if we're preventing homelessness from happening, how are we measuring or defining who is homeless and what constitutes homelessness, or what constitutes being at risk of homelessness? Seems like an easy conversation, but really not. Or at risk of justice involvement or justice involved, at risk of psychiatric hospitalization, or a high utilizer of psychiatric hospitalizations. Is a high utilizer defined as twice in 6 months? Is it 5 times in 6 months? Like there weren't any consistent standards for those measurements across the state or in statute or any of those things. So we're also looking at and working on being able to streamline the use of what is called our mandated data collection and reporting system. I realized as I looked at this morning that we put DCR, but I don't know that we defined what the DCR system is. And you know how you do that, like at the last minute, you're like, oh, we should have probably caught that earlier, but really it's the system that we use to report our outcomes at specific times during key events to our funders, which is the Department of Healthcare Services. And so it's exactly that. It's a data collection and reporting system, meaning that we put data in, but we don't necessarily get that data out. It's more of a repository. So we're looking at things like potentially revising some of our forms to include additional metrics, or augmenting the data that we collected so we can get to the additional information and outcomes that we're interested in reviewing. And so I guess in summary, we know that FSP services work, but it'd be really great if we had a quantifiable baseline as to why they work. Something that tells us that this number of this type of service by this type of staff works for this type of target population. We know that this has the best outcomes. And so we know FSP works. We're just not quite sure exactly why. And it'd be great for us to know that so we can make even better investments and use that outcomes data to transform our system to that performance-based model that LA has been implementing successfully. So next slide. Trying to get through this quickly so Brian has time for his. So all of that large framework from the state level cohort is happening. And then here in San Bernardino, we really wanted to focus on 3 additional county-specific local initiatives. And so one of those things that we really wanted to do is we're looking at the DCR, the data collection and reporting, being able to update the way that we not just collect data, but how we look at it. So right now, the DCR, we look at it from this very large state level, but it doesn't necessarily have the same meaningful impact for the line level staff. So the folks that are boots on the ground, doing all of this great work, they're not necessarily getting that feedback loop at that clinical level. We don't necessarily have it at the program level. It just sort of is reported to the state. So we're looking at ways to enhance that so that we can have that meaningful feedback loop incorporated at every service level. Looking at step down guidelines and making sure that as folks recover, because people get better, we know that. And so while FSP definitely is, once you're in full service partnership, you can always come back, you can provide those supports. That doesn't mean that we're going to keep you in that high acuity level of care forever. That's not what recovery says, right? Recovery is you get better and we move you and transition you, or you move yourself and transition yourself into a different level of care where, you're living your most meaningful life. And so we're developing kind of those step down guidelines, and then really looking at something that seems so simple, right? A referral process and those protocols, and really designing consistent referral pathways. And I'm going to go a little bit into that and why that's important for us in terms of referral. So next slide, please. All right. So let me just start by saying this. San Bernardino County, we are collaborating fools. We are honestly, I used to think that people would just say this and they were like, yeah, whatever, you're exaggerating. I am telling you, we have lots of solid built partnerships in our county. If there's a system that we can work with, we do. And so we do have lots of full service partnership programs that have specific referral pathways for services. So for instance, for our folks that are juvenile or justice involved, we have individuals or we also have folks that are transitioning from our IMDs and our state hospitals, maybe those that are frequently hospitalized for psychiatric reasons, et cetera. But we don't have a centralized referral process. So it's all very much because we have those strong relationships. The referral process is kind of built on those strong relationships, which is great for getting people into care, but not necessarily great for using like an outcomes-based model for program improvement. So we know that if we have like a solid and consistent referral methodology, that we can use the information that we collect from that in so many ways. So for instance, it can tell us which system is trying to access services in terms of more frequently. And so if we know that, hey, you know what, the hospitals are really leaning on us in comparison to these other referral pathways, maybe we need to take a look at, do we need to augment programming and services and funding in those areas and vice versa. So it kind of tells us where we need to build those partnerships, where people are accessing care. But it also tells us who isn't getting into the system. And so like as a hypothetical example, just say that, or who's not getting in the system of care, maybe where some additional resources are needed. So hypothetically, if our justice system, say if they were sending over a bunch of referrals and we reviewed that and 90% of those referrals, the folks didn't necessarily meet criteria, right, for our specialty mental health services. But we also looked at another variable based on our referral form and noticed that of those, most of them were maybe homeless. I'm just kind of making this up as I go. We might be able to like have a conversation and say, okay, I think you might be trying to utilize FSP services to meet your housing crisis. And instead, we could have a conversation with, say, our Office of Homeless Services and build a more appropriate referral pathway for those folks. So it's not just being able to access mental health services, but also because, again, we really do work in partnership in our county, being able to use that data to help other service systems build their framework. So we are looking right now at building those business processes, and hopefully we can implement. I think that's where we can have all these great plans. I don't know about anybody else, but where the rubber hits the road is when you actually start to implement those business processes. That's where everything is great on paper, and then you start doing it. That's when a lot of the coordination, a lot of the problem solving comes in. But that's kind of where we're at, and how we envision at every single point in care that we would be able to collect meaningful data and utilize that for not just program improvement, but hopefully performance contracting sometime in the future. So with that, I'm going to give you an even larger view and head this over to Brian Solis from the Mental Health Services Oversight and Accountability Commission.
Thanks, Michelle. That was great. And I really appreciate being part of this overall presentation. Boy, we're 46 minutes in. It's gone really fast. So I'm Brian Sala. I'm the Deputy Director for Research and Evaluation for California's Mental Health Services Oversight and Accountability Commission. And I'll just refer to us as the Commission because that's a really big mouthful. I'm going to give a quick nickel tour of who we are and what we do, where we fit in the system, talk a little bit about some of our innovation initiatives, and then wrap back to talk about the FSP project and some of the data work we're doing that's associated with where I think that project is going. So just very briefly, for those of you who are not familiar with California's structure in terms of the public mental health system, we have a very devolved system. So under a Medicaid waiver, our Medicaid programs for mental health are administered at the county level. We have 59 mental health plans. That's most of the counties. There's one collaborative across 2 counties, and then there are two sub-county units that have their own independent mental health plans. And then I'm just going to talk about the integration across some of those tools and funding mechanisms. So we're the Mental Health Services Oversight and Accountability Commission. We were part of the passage of the Mental Health Services Act in California in 2004. And that act is both a policy tool and a funding mechanism. On the funding side, it includes a surtax on high-income individuals in California, personal income tax surtax, which generates now a bit over $2 billion per year, 95% of which is distributed on a monthly basis to county behavioral health departments or mental health plans. Those county departments use this money to supplement and leverage other funds. And there are a couple of other major categories, obviously, Medicaid funding, or in California it's called Medi-Cal, and the match for Medi-Cal largely, and I'm sure others can correct me on the details on this, but a great deal of the match on Medi-Cal is paid for through what's known as realignment funding in California. So the intent here of the MHSA is funding of last resort, to do things that those other funding streams are not allowed to do, to be integrative, and to support the planning process. So the counties are required under the MHSA to engage in a very in-depth, community-driven local planning process before they can spend MHSA funds. And as you can see on the slide, there are three primary components for local programming with two optional components. The primary components, which are funded directly in the funds distributed by the state to the counties, community services and supports, and FSP is about half of the CSS component. And these are services for individuals with serious mental illnesses or children with serious emotional disturbances. Prevention and early intervention funding, which is 20% of the funds distributed to the counties. It's actually a little bit less than that because there's some math involved, where counties are required to invest upstream on reducing the numbers of individuals who are in need of serious mental health services. So there are prevention programs, there are early intervention programs, there are programs to address stigma and discrimination. There are programs to build recognition of the early signs of mental illness, all designed to move upstream in the service system, with the logic being that if we catch people with needs earlier and provide them with appropriate services, they will be much more able to maintain a full participation in their communities and management of their own lives, and not need the same level of intensive services that may be provided in an FSP, for example. The other two components, the third component that's funded is innovation. Counties are required and are funded with about $100 million per year, 5% of the MHSA funds distributed to them, to design and implement projects to identify, test, and implement innovative solutions to mental health challenges, whether that's administrative, research and analytics, or services. Basically, any component of the service system could be addressed by an innovative project. And the FSP project itself is an example of an innovative project. The other two are workforce education and training for building the workforce, and a long-term capital grants sort of component for acquiring or developing facilities, acquiring or developing technology systems. I'm just going to turn quickly to the commission. We were created as part of the Act, and our role is really to provide policy guidance, technical assistance, and capacity building support, learning opportunities, and incentive fundings. And as part of the kind of incentive structure, the commission also has an approval role over county innovation projects. Incentive funding includes competitive grant programs. Recently enacted budget in California includes about $250 million in one-time funding to support school-county collaboratives under what's known as the Mental Health Student Services Act in California, to improve early recognition of student mental health needs and to better link students and their families to services. So this is one example of incentive structures that the legislature and the governor have invested in through the MHSA, although that also includes some federal funding this time around. The commission is particularly interested in catalyzing county investments in potentially transformative system changes, recognizing that even in California with the MHSA, there's simply not enough money in the system to meet all of the need doing business as usual. So the challenge we try to put forward to counties, and the challenge that counties have very often taken up, is how do we change the way we do business in fundamental ways? How do we fundamentally transform how we're doing business so that we get better? So it's not merely program improvement projects, which are very important in and of themselves, but also recognizing that there may be some fundamental restructuring that we should be considering in parts of our service system. And an example of that focus is what we call our innovation incubator. So if you go to the next slide, please. So we've been talking about our FullService Partnership project, which was one of our major initiatives in our innovation incubator. The legislature and the governor authorized the commission several years ago to invest several $1 million to help incentivize changes that could lead to significant reductions in the numbers of persons deemed incompetent to stand trial in California. And just to scale things, on the order of 8 to 9 out of every 1,000 adults arrested in California is deemed incompetent to stand trial. So it created a tremendous burden on individuals who are not necessarily getting the services they need, on the criminal justice system, and on our communities. And we applied this incentive funding with a very broad prevention lens, to fund or co-fund several projects, as noted here on the slide. FSPs, as you've heard, are a $1 billion per year investment, and I'll come back to that in a later slide to talk some more. Two others are a project to experiment with psychiatric advanced directives. These are intended to help consumers better manage their own care in a mental health crisis. As with more standard medical advanced directives, a PAD is intended to clarify and secure adherence to a consumer's wishes before the consumer may lose the ability to provide informed consent in a crisis. One intent is to avoid unnecessary escalations that could lead to arrest. As we've all seen in the news repeatedly for years, of individuals in a mental health crisis where a family member or other calls the police because they don't know where else to turn. And all too often, those events end in tragedy. Sometimes it's because of a lack of training. Sometimes it's because of a lack of preparation. But all of those are, in principle, avoidable crises or avoidable tragedies. And this is one of the examples of projects that we're pursuing. We also have another fairly large, for us, competitive grant program that funds personnel for crisis services programs across the state. A second major project that we funded or co-funded through the Innovation Incubator is known as the Data-Driven Recovery Project. And this project is intended to improve data sharing and collaboration across local agencies, including law enforcement and various service agencies within counties. Again, we have a very devolved system. And so helping our diversity of counties, as was mentioned earlier, we have this huge range from Los Angeles County with well over 10 million individuals down to Alpine County with only a couple thousand individuals resident in the county. And yet those counties have very similar administrative overhead challenges across the various services that have been devolved to them. So this project is really designed to supplement, support both monetarily and through expertise in helping those counties think through how can they better collaborate, break down silos, and better anticipate how they can make use of their own internal knowledge to better serve individuals in need. If we go to the next slide, then I want to turn back to the FSP project and talk about some of the data work that the Commission has been doing. This slide is about a data linkage that the Commission performed between about 2 decades worth of arrest data managed by the California Department of Justice and mental health client data in a broad set of databases managed by the California Department of Healthcare Services, and we partnered with them as well. So Michelle mentioned earlier the DCR, the Data Collection and Reporting System. There is a second database that includes service records, service minutes, and other aspects of mental health services for individuals with SMI. And we've been trying to use our role as a statewide entity to leverage the power of the data across the state, both in the Department of Justice. We recently acquired a data set from the California Department of Education for student level data, identified data. We've worked with the California Department of Public Health, and we have vital statistics records, again, at the individual level, birth and death data. We're working towards hospitalization data, social services data, and a variety of other statewide data systems so that we can try to surround the individuals in the service system with already available data collected by the state in different places for different purposes in order to talk about outcomes, to leverage data that's already there rather than counties to have to recreate many of these measures at the local level. So here, through this partnership with the Department of Justice, we linked arrest data at the individual level with FSP partner data to examine the essentially suggestions about the treatment effect of FSPs. So we looked at the 12 months prior to enrollment, the enrollment period, and the 12 months after exit. Sorry, my lights turned off automatically. The 12 months after exit from a full service partnership to examine arrest rates for that population. And what we found is that the transition from the 12 months before to the during period across the board, we're cutting arrest rates almost in half. Now, I want to caveat that in that a very large percentage of FSP partners had 0 arrest records in the data, in the DOJ data, before, during, or after. So this is really largely driven by individuals, you might call them high flyers or repeat customers. And it's also the case that a very large percentage of the arrest cycles in the data end in dismissal. That is, a lot of these arrests aren't turning into convictions. And many of those arrests may be quality of life violations or perceived quality of life violations. And we'd really like to find ways to avoid unnecessary law enforcement involvement, right, with individuals. That is, how do we better avoid creating crises where there don't need to be crises between an individual with mental health needs and the public safety system? And certainly what we see so far is that full service partnerships from before to during, and then this shows from before to after, are having a substantial impact on the propensity for individuals to be arrested in the first place. That's very encouraging news. I will say, in alignment with the whole third sector project on FSPs, we don't yet have the ability to say a lot more than that. The statewide data system does not sufficiently identify the program or the provider network around what you would call an FSP program. As Lisa and Alex noted, Los Angeles has 196 providers involved in their FSP program set. Under the law, counties are required to provide FSP services to children, transition-age youth, adults, and older adults. And many counties have multiple programs that are serving specialized populations. So this is just an example of the Commission's agenda to leverage statewide data to support outcomes-driven decision-making in mental health programs and services. We're really excited about continuing to partner with Arel and her team, with the counties, and thinking about opportunities. One other example of that, we had a pilot project with several counties recently where we developed we'll call it a survey instrument. It's really a characterization tool for the individual properties of a full service partnership implementation. What kinds of services, what kinds of personnel, what kinds of training, what kinds of assets and resources are available in the program. And the intent of that particular pilot project was to see whether we could do the linkage between individual clients and the individual implementation by which they're being served, and then examine the predictors or the correlates of who leaves a program early. Because counties are investing a lot of resources in onboarding FSP clients, but if they're not in the program for at least 6 months, we believe, they're not getting the treatment effect. So we're very interested in what does it take to achieve strong attachment between an FSP client, a partner, and the program provider, so that they're able to achieve what they joined the program to achieve. And those are some of the downstream things that we will be working very hard on with our county partners going forward. I'm going to stop there because I'm over my time, and we're hoping to be able to spend a good chunk of time on Q&A.
Thank you, Brian. Hello, everyone. I'm Nicole. I'm the second half of the third sector team here. I'm also a director out of the San Francisco office. We're going to do one more interactive Slido question before we get into the Q&A. So just as a reminder to participate in the survey, if you go to slido.com and then type in the code MHTTC, you will see this pop up on your screen. I will enable the survey in just a moment here, but I wanted to just give you all a moment to read through the question. So the question is, what element of your local outpatient mental health system most enables an outcome focus? And we've talked about data a lot today. We've talked about services, policy, funding, external relationships, and internal culture. And so I know that it's hard to pick just one. You actually can pick multiple of these if you'd like when I launch the poll. But we'd love to hear from you. Which one of these really most enables an outcomes focus from your perspective? Okay, it's looking like data and services are topping the list. Funding made a comeback. I think it was at the bottom there at the beginning, but now number 3, external relationships. I know Lisa talked a little bit about that. Lisa and Alex talked a little bit about that in the beginning. And then policy and internal culture. Well, great. Thank you all that were able to participate in the survey. I'm going to go ahead and move us into our Q&A portion. So we've had, I think, maybe 1 or 2 questions in the chat so far, in the Q&A box, excuse me. Please feel free to keep entering questions as we go through. I think we'll have about probably 15 minutes to answer questions interactively. So I'll just start with the ones that we already have. But again, I encourage you all to please go ahead and add more as we continue the discussion. So the first question that we received is, can you talk a little bit more about how you work in school districts? And I think Michelle was going to go ahead and talk a little bit more about this from the San Bernardino perspective. So I'll pass it to you, Michelle.
Hello. So thank you for the question. That actually is a great question. So I can tell you these things. We have about 33 districts in San Bernardino County, which equates to about 592 school sites. And about 435 of those 592 sites are served by community-based organizations that we fund to provide services across a continuum of care. for children and youth in our county. So that's about 73%. We also have I don't know if it's unique, but unique constructs in terms of out of those, we also have 5 school districts that we directly contract with and they actually provide mental health services in their school districts, and they're responsible for providing the local match to be able to draw the Medi-Cal funds down. So that's kind of like the larger picture of how the delivery of services. We have an entire continuum of services that are offered in school districts. We do preventative types of services. We do early intervention. We provide treatment services across the continuum, starting from, like mild, moderate, all the way to being able to coordinate and support the coordination of children and youth into higher levels of care. So we offer those supports really in collaboration and connection with our school districts at that level. We also partner with our San Bernardino County Superintendent of Schools to take more of a systems approach to being able to provide like some capacity and training to our school district partners. So we have an agreement with our Superintendent of Schools office. We fund a team that provides training and technical assistance for positive behavioral interventions and supports, as well as the multi-tier system of supports. So we really have a pretty well-developed system of care and supports in coordination and collaboration with our school partners. Always an opportunity to do better, 100%. But we definitely have like the core infrastructure in place to be able to help support our school districts and our schools across the county. I hope that answered the question.
Thanks, Michelle, for fielding that one. Our next question is around the types of outcomes that we've been discussing. So we have the question, it's the types of outcomes we've been discussing are, of course, extremely important and can be linked to a client's quality of life. However, it's interesting that none of the ones I've noticed being talked about so far have to do with mental health and wellness per se. For example, the discussion of reduced arrests is interesting, but as Brian noted, this actually represents a very small number of clients and seems more like an outcome that systems prioritize versus the client in general. So the question is, what about outcomes that look at client perspectives on whether their lives are improved? Is there any plan to examine that?
So I can maybe start on this, and then hopefully Alex or Lisa can jump in a little bit, or Michelle. It's interesting. There are a number of interesting facets here. One of which is the California's Regulatory Division of Labor. So while the Commission is primarily a policy body, we do have some regulatory responsibility over the prevention, early intervention component of the MHSA. Where counties are required to identify outcomes at the program level, outcomes for clients being served or individuals being served or groups being served, and metrics for those outcomes, and then to regularly report on analysis of those outcomes every 3 years at the program level. We don't yet have a parallel structure of required outcomes reporting for the CSS component, which includes FSPs. There is a piece of the FSP component, and Michelle talked about it with the DCR, that does require tracking of certain outcomes for individuals. And probably the one that most closely tracks what the question was getting at is whether or not the client who's exiting has met goals. So consumers who are partners in an FSP, there's a reason it's called FullService Partnership. It's a partnership between the provider and the individual being served, and that they collaboratively identify the goals that the partner is working towards within the FSP. And those goals can be multifaceted. And then there's specific reporting requirements on statuses for partners. housing status, employment status, criminal justice involvement status, educational status where appropriate. So there are key events that are supposed to be tracked, a change in status, and then there are quarterly reporting on statuses. So that's part of why some of our emphasis has been on statuses for these major categories. But it's undeniable that that employment and housing are major contributors to the welfare of individuals in the mental health system. We're pretty sure that an individual who has meaningful things to do in their life, such as a job or other meaningful activities, is in a much better place than individuals who don't have jobs or other meaningful activities. So these are important, if not direct, indicators of wellness. I definitely appreciate the thrust of the question, but we don't really have, at the state level, clinical outcome measures built into the FSP system.
I think this is a very interesting question because, part of our philosophy of treatment in FSP is to have everything be very client-driven, client-centered, collaborative emphasis with our clients. However, we do look at statuses that are really more, part of a system. I don't think I've ever had a client come to me and say, my goal is to stay out of jail. But he or she has said, I want to have my own place. I want to be able to have friends over. I want to have more, control over different decisions in my life. And it's sort of like what Brian had mentioned. So we know that these are areas that are significantly impacted by being incarcerated, where you would kind of lose the ability to achieve those goals. So I think the job of the FSP team is to tie together the goals on a personal level, those things that are meaningful to each individual client, and be able to see in the broader system what else impacts it. I mean, that being said, in this first implementation of our FSP transformation, we had a set of outcomes that we tied to incentives, and we knew that those are going to be very elementary ones to begin with. They're around incarceration, hospitalization, homelessness, and retention. But what we're hoping is that as we go through these 2 to 3 years of piloting this, we will be able to dig deeper and find the ones that we hear repeatedly from clients and find meaningful ways and accurate ways to capture that.
Thank you, Brian and Lisa. And I'll just add in there, the 6 counties that are currently working together on the multi-county innovation project are looking at those same things, homelessness, stable housing and justice involvement. But we're also currently discussing potentially a measure for social connectedness, which would be a little bit different. And we're trying to kind of navigate all of the difficulties of getting data for a measure that has not been traditionally collected, and especially in a consistent way. But it has come up a lot from both, the providers we've been talking with and some of the consumers as something of interest. So hopefully we'll have a little bit more fleshed out answer for that particular measure here in the next several months.
I just wanted to add something really quickly, and I think Lisa's aware of this as well as a department. Maybe at the state level, we're not collecting some of these data. However, at the county level, we definitely, something that our director has moved forward on, and something we're looking at is also using, I think we were looking at contracting with the Gallup, so looking at a well-being survey. So regardless of any client coming through our doors for outpatient care service all the way to FSP, we're looking at specific domains. I think it's either 5 or 6 of them that it's in regards to meaningful, what makes their life meaningful. If it's employment, it's housing, it's social connectedness. So we are looking at that. So just to answer the question, yes, all of it. We at LA County, I think we collect a lot of data. Sometimes data that I'm like, are we analyzing this stuff? Well, why are we asking for it then? So I think that's something that we definitely do. And I think that it's maybe not necessarily related specifically to FSP, but it's actually across the board for any client coming into through our doors.
Thanks, Alex. I think we have time for one more question. So I apologize if we don't get to your questions. We can certainly try to answer some via the Q&A box if we don't address it verbally here. But let me see. The last question we're going to go with for today is, I notice we are focused on individuals with SMI. Are FSPs also open for individuals who are at risk and don't necessarily have an SMI SED? Our program sees more at-risk individuals compared to those with SMI SED. I think Lisa and Alex, you all over in LA County dealt a little bit with this, with the at-risk population. Did you want to talk a little bit about that?
Sure, I'd be happy to. This was quite a dilemma for us because I think nobody wants to wait until somebody who's not SMI becomes SMI to intervene. So I think that was a big concern. But we did pilot an effort earlier on to include the at-risk category with our focal pop criteria. And what we found was we couldn't adequately address all the needs across our system for both populations. Given the limits in resources, both financial and human resources, and in terms of focus, we found that we needed to refocus on those highest acuity and not just SMI, but the highest acuity SMI, most vulnerable, meeting usually multiple focal pops. And that would be where we could be most effective in our FSP efforts. However, simultaneously, we had to embark on a mission to enhance our other outpatient services and our homeless services so that we could be responsive to people with serious needs who may not be in that highest SMI population. And if Alex might want to add anything to that.
Well, I'm good, boss. That sounded very good to me.
Great. Well, thank you all so much for answering a couple of those questions. In the interest of time here, I'm going to start to wrap us up. So just to kind of bring everything back together, a quick summary of some of the things we talked about over the last 90 minutes, the key takeaways, if you will. One, we talked about policy, services, data, funding, and how they are all aligned around long-term meaningful outcomes, and really the importance of internal and external relationships. Going along with that, stakeholder feedback is especially important when driving large-scale change, as we heard from the work being done in LA. In addition, locally, agencies can use outcomes to better understand client and system needs. And Michelle demonstrated how counties or local agencies can do that both within their own geographies and also collaborate across geographies in order to achieve those goals. And then finally, the state can also help push for outcomes by supporting convenings and learning communities, helping to navigate the integration of data, and also allowing for more flexible funding in order to promote innovation. So with that, I have one last survey for you all. We're curious about, what did you learn today? What did you hear that maybe you hadn't heard before? What did you hear that was maybe a little bit thought-provoking, or maybe what did you hear that has left you wanting to learn more? So if you pull up slido.com, this is just a free text. So you can kind of go in there and share any learnings or things that you'd like to continue learning about with us via this poll. And again, that's slido.com, and then you just type in MHTC. How to best use data, yes. Meaningful outcomes, how a program is looking to grow and serve the population. learning more on American Indians and FSP. Where do they live? Where are they from? What services are provided? Learning more about implementing in my area, how programs are looking to grow, FullService Partnerships. As you learned more about it, made me think of the wraparound approach we do at our program, but on a bit bigger scale, certainly. I know this is a tougher one. We asked you to free form here. So I'll just give it another 10 or 15 seconds, but this is really helpful for us as well on things that you all are interested in learning more about. And when I head to the next slide here, which I'm going to do in just a moment, you will see that if you'd like to learn more about the Multi-County FSP Innovation Project in particular, you can always go to Third Sector's website. We have a page dedicated to it, and we try to update it with resources as often as we can. You can also feel free to reach out to Arel or myself. Our emails are on the slide that have been distributed. We can also certainly pass along additional questions to all of the wonderful presenters that are on the call today. And with that, I think I'll turn it back over to you, Ingrid, to kind of wrap us up.
Great. All right. Well, I'm really so grateful for everything shared. It was so much, and I'm glad that further questions can be fielded by Aurel and Nicole. Here's all of our social media info. And that pretty much concludes today's session. I really want to give a special thanks to the folks at Third Sector and all partners who presented today. It was an incredible sharing of info.